morning, everybody. My name is Luigi Boni. I'm professor of surgery in Milan, and I'm chief of the Department of Surgery, Minimally Invasive Surgery at the Policlinic Hospital in Milan. We have a quite busy department, and I'm the first gastrointestinal surgeon that is speaking today, so that will be very interesting. And I can tell you what, now when I go around meetings, in different meetings in GI surgery that we go around the world, everybody is talking about AI, and I want to quote my good friend Ai2m, that actually is thoughts about AI and surgery. You know, it's like teenager when they talk about sex. You know, everybody is talking about it, everybody would like to have it, but very few really knows about it. So this is actually what happened in meetings in surgery, not this meeting, because Filippo managed to actually have a great crowd, a great expert meeting, but definitely this is not the real life situation. You know, many people doesn't have a clue what AI and what AI can do for surgery. Well, what I would like to start, like just to strengthen one thing that I give it for granted, but sometimes it's not. I actually, you know, would like to push all the engineers to talk with the surgeon and to really understand what the surgeon needs from AI. Because if you take a 100 surgeons that actually have a busy clinical practice, and you ask them, do you really need this AI system that recognizes your instrument when you get in and out? Probably nobody say yes, because we don't need that. Do you really need a system that recognizes how many errors your hand does, or how many movement your hand does before reaching the target? Most of the people will say no. I give you an example. In tennis, Medvedev is the #3 player in tennis in the world. And if you talk to a tennis player, you say, he can't play tennis. This is completely wrong, everything that he does. And if you apply an AI system that actually calculate how many errors he does when he makes a movement, he will say that it's rubbish, but it's #3 in the world. So in surgery, it's a very practical thing. And actually sometimes, engineers, they overload their activities with something that doesn't have any use for the clinical practice. As a surgeon, I found very difficult to understand all the kind of definition that you can find in the literature about AI. But I can tell you there are 3 aspects that are very important for us. AI in surgery can be very useful for the intra and perioperative decision making. And when I'm talking about decision making, it's actually having information about what can I do for that specific patient in that specific moment. So maybe AI can collect all the data that have in the literature about this specific disease, they collect all the data that have intraoperative data. And maybe for this specific patient, maybe giving an anastomosis for a low rectal cancer is not a good idea, because the data coming from the intraoperative findings in the anesthesiologist room can actually help him out to take the decision, better a stoma, because this patient is going to have a leak and then you're going to die. So intraoperative decision making, of course, postoperative decision making, the same way. A lot of data that we have it, and we rely on our experience. But we have a lot of information. This information can help the surgeon to discharge the patient at home, to discharge the patient in a facility for rehabilitation, or keeping him in the hospital, because if he goes home, very likely he will have a complication and will come back to the hospital. So that's what we need. And then what we do need. Well, we need computer vision. I come to the topic of my presentation. We need computer vision, which can help us to enhance what we can see during surgery, and maybe for the next step, to create a no-fly zone in order to prevent the surgeon to hit or to damage important structure during the surgical procedure. And we know that we have no-fly zone, and the fantastic work that the group that was led by Dr. Mascagni just presented before actually show us that now you can recognize structure, you can recognize anatomical area, you can recognize instrumentation as well. So this is what we need, but we need this in real time and in very good precision. So this is why we start working with this company that comes from Japan. It's called Ai2m, and it's developed this system that is called Eureka. Eureka is a very interesting system because it is a real-time system that allows to detect during surgery different anatomical structure, and is done in a very precise way with 0 delay, or at least 0 perceivable delay from the clinical point of view, and it gives information, enhance the visualization during surgery of critical structure, and also help to dissect the correct plane. It's got a CE mark, so this is great for us. It's not CE mark for clinical decision. It's a CE mark for research and educational purposes. This was very smart because it takes much less, but they're actually applying for CE marking, also for clinical decision. The way it works is the usual way of any artificial intelligence system. They have collect a lot of videos, they come from Japan, so they have a lot of experience for Japanese patients, and especially for upper GI surgery, very few for colorectal. And they take this, they analyze the complex structure, then they made a segmentation, and they work with a neural network for developing an AI algorithm that actually can be applied. And the system itself is a box as big as this that is connected to your camera with an SDI cable, and the camera and the system itself is connected to a monitor that you can look and you can do surgery with that. And there is, I will show you that. As I mentioned, the process that actually has been created by a segmentation of the surgical video that has already been done for the Japanese population, for upper GI mainly, so it needs a little bit of development. And then during surgery, I will go quicker, it was able to recognize structure. As you can see, it can recognize connective tissue, that for us are the embryological plane of this section, can recognize the pancreas, can recognize the hepatic vein, can recognize the ureter, and can also recognize a specific structure like artery, microvascularization, and can also detect in a specific steps also a period where there is intraoperative bleeding. The system is very simple. It's got a software that actually appears in your monitor. You can choose to identify up to structure simultaneously. So you can choose either the connective tissue, the ureter, or the pancreas and the vessels. You cannot do more than two. I think there is no need for more than two because too many information that create too much confusion. And this is actually how it works. That is, for instance, to identify the connective plane. As you can see here, this is live. It's not really, re-elaborated. Then you can do it live. You can see all the connecting, dissecting tissue. This is a rectal resection where we spare the inferior mesenteric artery, sigmoid resection, we spare the sigmoid artery. And as you can see here, we actually have the identification of the dissecting plane. Very nicely, very precise. This is a total mesorectal excision. You can see the mesorectal plane highlighted by the system, posteriorly as well as anteriorly. So that's enhance our visualization. Of course, the system is as good as the system has been trained. So this is why we're working with them, especially for our population. It's not the same as the classical Japanese population. This is a complete mesocolic excision where actually you have to go through embryological plane, and once again the system is able to recognize the dissecting plane that is required to be dissected during this specific procedure. This is how he highlights the pancreas. You can see here there are two different ways to highlight the organ, a continuous way or a pulsating way, depending on the preference from the surgeon. And very interesting from a colorectal cases, identification of the nerve. These are the pelvic nerve that actually you can see here highlighted by the system, so you can simultaneously highlight the dissecting plane as well as the pelvic nerves. And just to show you that actually works very well in real time, this is a live surgery that we did last year in the Milan Colorectal Congress that we do every year. As you can see here, you can highlight in this case specifically the dissecting plane in blue and the ureter that you can see, that you saw in the image just before. And you can see here how you can really be extremely precise in the dissection. You see the ureter highlighting in the background. And you can just imagine, as I mentioned, there are some publications that actually demonstrate the efficacy of this kind of system that can, of course, be improved, especially according to the type of surgery that you're doing and the type of the population. This can be also enhanced by using simultaneously fluorescence-guided surgery as well as AI enhanced visualization with the Eureka. As you can see here, the green one is lymph nodes, actually are identified by ICG, and the blue one is the dissecting plane through the embryological plane. And if you think about, of course, there are still some work to be done. The idea is actually to have all this segmentation, of course, automatized without the need of having a supervised segmentation, as actually has been done so far. But the most important thing is actually if you have this kind of enhancement, you can couple this kind of visualization with a robotic system, and then you can really create no-fly zone where actually the surgeon is not able to go towards the ureter, as you can see. You cannot go outside the dissecting plane that has been identified, and that's definitely will recreate a system that democratizes the quality of the surgery worldwide. And I thank you very much for your attention.